about to go to the critical care meeting in Hawaii, and I think what you're going to get in Hawaii, what you're going to get today is going to be the Reader's Digest version of all the important stuff that's going on, because this is a really hot topic in critical care now. So anyway, everybody knows Keith. I don't need to introduce him. Keith?
Okay, thank you. Well, that's not too loud. Anyway, I want to talk about, again, what Dr. Weigel just talked about was this new concept of dysbiosis, and really, what the hell is dysbiosis, right? It's not something we study, it's not something you learn about, but the NIH is very clear. They defined it late last year as a disruption of the homeostasis of the microbiota. And what's most important, if you look further in their definition, they're saying this is turning out to be as important as a genomic disease. And this dysfunction of this microbiota probably has as much to do with the development of inflammatory disease, obesity, diabetes, cardiovascular disease, adult cardiovascular disease, and then more importantly, what I want to talk about most is nosocomial infections and infections in the ICU, and how our disruption of this microbiota has led to this phenomenon. So I want to start and kind of to do full circle with this and really start talking about the microbiome, how it relates to critical illness. But it's not just unique to critical illness. Any acute illness, any hospital, it's the same thing. I'm just an intensivist, so I concentrate in the ICU, but it is translatable to the entire hospital. And how that develops dysbiosis, how that develops nosocomial infections, and particularly I'll give an example of ventilator-associated pneumonias, and then talk about some new paradigms that maybe we need to look at as far as trying to prevent this from occurring and getting further out of control. So if you look at the history of antibiotics, and I actually did an ID fellowship before I did a critical care fellowship, so I've been into this for a long time. But if you look at antibiotics themselves, we were always antibiotic centric. You know, or bug centric first. You know, someone came in and they died of pneumococcal pneumonia. Ooh, that's a bad bug. You know, then we said, oh, well, we've got all these antibiotics. Well, this guy didn't respond to the antibiotics. Boy, it must be a bad bug. When in fact, it was not a bad bug. It's just there was a lot going on that we've never really accounted for, but we always either blame the antibiotic or we blame the bug itself. But if you look at the history, in between 1900 and 1980, antibiotics have been contributing about a 22-fold drop in mortality. So they have done some good. Now most of that, if you look statistically, was the drop between 1930 and 1950. And that was drop in pneumonias and with the introduction of sulfa and penicillins. So that's the majority. So antibiotics have done good, but we've kind of come full circle because particularly if you look at the ICU, but we could say this about hospital use. We've given the antibiotics, and you could do this outpatient. We've got a cure. Yeah, we got a cure, but what else have we done? Well, we've created resistance, and now, as I explained dysbiosis, we've developed this dysbiosis, which is actually requiring us to use more antibiotics. So we've created this full circle of antibiotic use that we just can't get out of. And a lot of it is habit. A lot of us were used to it. And a lot of it is, well, their own antibiotics. What do you want me to do? Now they're septic. Well, their own antibiotics. What do you want me to do? And we've created, again, a lot of our own problem. If you look at this, and this is the scary numbers, is 37% of hospital prescribed antibiotics actually are inappropriate or meet no criteria. So that means all of y'all are contributing to the dysbiosis problem because, one, we give antibiotics way too frequently, and the other is sometimes patients demand it, we just are really helpless in, I think, prescribing these antibiotics. If you look at the ICU itself, and this has been data that's collected by the ICU section of the CDC, 38% of antibiotics are completely unnecessary or meet no criteria. So again, what do? Someone calls you with a fever, you order blood culture, probably start antibiotics, and then what happens? Nobody wants to stop them, right? And blood cultures come back 2 days later. What's the discussion? Should we stop antibiotics? Usually they don't. Usually they carry a course, 10, 14 days if you look into the ICU. And if you look at just up to 1996, mortality from infectious disease increased 50% in spite of those antibiotics. All the antibiotics. If you look at 1996 to 2016, which is the next best thing, septicemia rates have doubled. Mortality has gone up probably about 60%. Now we are seeing sicker patients, so it's not just antibiotics. I mean, we're seeing people that have survived their third round of chemotherapy and their burns and all of these things that we've been so good at saving them. But then we throw in all these infectious diseases and we give these antibiotics, and we're really not making a big impact anymore. So that's a pretty high number. And again, that's 2016. And it looks at this, it's a huge cost, and the financial expense is about 30% of a hospital drug budget. So that includes your biologics, your chemotherapies that are $60,000 a year, $50,000 a year. So 30%, even in spite of those huge number of drugs, we're spending a lot of money and a lot of time on antibiotics. And here's even scarier. It's in the Journal of Medicine. This was just out last year. Estimates that about 450,000 cases of resistant Clostridium difficile occur. This is all antibiotic related. So that's a lot of patients. It's 500,000 patients a year are getting sicker because of drugs that we're using. And we're trying to do good. We're trying to get through their problem or their infection, but we also have created a huge problem, and this is where dysbiosis comes in. So why should we be concerned? Well, it's interesting. We have about 30 trillion human cells. And any of the cells express, even though we have about 36,000 genes, between 20 and 30 at any one time, just for normal machinery. So if you look at the human microbiome, they have us outnumbered by about 10 trillion. And more importantly, they express between 2 million and 20 million different gene sets. About 10% of those are antibiotic resistant generating genes. And they've done that because they've been exposed to antibiotic burden for a long time, and they're actually developing more and more of these transfer genes, and I'll talk about those in a minute. But this is the problem. We have a huge, huge growth of these type of genes. And if you look at where all the bugs are, anaerobes to aerobes to anaerobes, you can see that the stomach has 10 to the second colony-forming units per milliliter. And if you get down to the colon, it's 10 to the 12 colony-forming units per milliliter. So huge bacterial burden that we have. But these are not bad bugs. We've gotten these bugs, and we have these bugs mainly because many of them are health promoting. And if you look at this, you can see kind of where they are. But all of these, some help with digestion, some help with pH, some help with vitamin absorption, bile acid metabolism, and others help with absorption of water, etc. But this is what happens. Antibiotics don't kill just the pathogen. If you have someone and they grow Pseudomonas, you give them Rocephin, or not Rocephin, say ceftazidime, one of the other anti-Pseudomonals, they kill a wide range of bugs. And particularly a lot of these are these health-promoting bacteria. And if you look at this is kind of interesting. Can't show you, but if you look at mice that you just kind of make them have a sterile gut, all of the things that occur intestinally, they lose their lymphocyte mass, they have thinner types of intestinal epithelium, their lamina propria has fewer cells, they have a very low Th17, which is an anti-inflammatory or pro-inflammatory blocking type of committed T cell. You have significantly reduced issues. You also have bacteria that if they overgrow, they also become, even if they were helpful at one point, can become unhealthy. And that's what the microbiota that we're studying is. What happens when you don't have enough of this or you have too much of that? And how can we try to help restore that and get people back to health? And this is really a simplistic cartoon, but it really shows what happens is we actually have a very, very nice microbiota homeostasis system where there's symbiotes, there's commensal bacteria, and there's pathogenic bacteria. And if you start losing these symbiotic bacteria, and that's the majority of the bacteria that we have, the pathogens become higher growth, they have more of them, and then through quorum sensing and other types of communication mechanisms, they actually start taking over the system. And this is what happens because when they do, they develop inflammation. And we know that all disease is inflammation one way or another. And this is really what has happened. Now, much of this occurs through quorum sensing. And I don't know how many of y'all know about quorum sensing, but bacteria communicate. They communicate very, very well. And there's actually several ways they communicate. They communicate species to species, and they can communicate non-taxon to a different tax. And they do it through these different type of communication signaling. And what it is, you just take a mean bug, and they basically send out tweets. And basically, how many tweets that they receive back depends on how aggressive they get. Because what happens with quorum sensing is you normally, these bacteria secrete these proteins. They're called autoinducers, and there's several. We used to think there was only 2, but there's probably up to 6 or 7 right now that we know of. And they normally secrete a certain amount, like a machine. It's like a car idling. It puts out a certain amount of exhaust. You get 3 or 4 cars idling in the same garage, then that exhaust becomes more toxic. And what happens in quorum sensing is that these bacteria start to multiply, or they become more and more of their same type. They start increasing the concentration of these autoinducers. When that happens, it goes back to different types of receptors, and actually that goes to the gene and tells the gene to make pathogenic factors. So if you look at staph that secretes an exotoxin or strep that eats exotoxin, they are the highest point, or Pseudomonas with cytotoxin, which is one of the more pathogenic. It's all related to the concentration of bacteria that occur. So what happens when we mess up the microbiome, we get these pathogens that increase their proliferation, and then they start talking. And once they start talking to each other, then they really start to build resistance patterns. And there's several. You have intracellular autoinducers, you have cell surface autoinducers. They all do the same thing. They go and they stimulate target genes to make pathogenic organisms. The reason they do that is competition for food, we think. Some of it has to do with they say, hey, there's a lot of us here. We're going to stimulate a severe immune response. Let's get together and try to protect each other. And this is where biofilm probably comes in. If you look at this kind of motion film, as the increase, when you start seeing red, that's biofilm formation. And this is a computer model. As you increase these autoinducers, you can see that this huge biofilm starts to form. And that's really what protects these bacteria. And that's what happens when we mess up the biome, or the microbiome, is bugs that would maybe keep this from happening have been dropped. So all you have is these Pseudomonas left, or a bifrag left, or Clostridium left. And that's the ones that start causing the problems with biofilm. And there's other things that seem to happen that's kind of interesting. One, we know that pathogenic signaling proteins can stimulate the dendritic cells, which actually go on and cause a committed T cell, again, to go IL-10, IL-17, IL-23, TNF, all of these things. But what it does is, if you have certain of these bacteria, it actually kind of regulates the inflammatory response. And if you don't have these dendritic cells, then you get a more pro-inflammatory, so if you get an inflammatory signal, there's nothing to counteract it at the T cell level. So again, messing up the microbiota messes up these T cell signaling pathways that probably get you either to a pro-inflammatory T cell leaning process versus an anti-inflammatory. And this is what we think is going on in the ICU all the time, which is maybe why we have such a problem with nosocomial infections. And so we know a lot of things that go on with dysbiosis. There's genetic causes. We know there's certain mutations that seem to set you up for it. We know that diet, colonization, medical practices, including vaccinations, which we don't know why, but they seem to also affect it. It may be that they're just affecting the T cell function. But they all generate this dysbiosis that leads to either health or disease, depending on how severe it really is. So what does that have to do with nosocomial infections and ICUs and the hospitals? Well, if you look at medical and surgical patients and you look at their breakdown, pneumonia, urinary tract infection, bloodstream infections are the most common. And they're so common that if you look here, how many get Foley's? Almost all of them. How many get central lines? A whole bunch, more than 60, 70%. How many are on a ventilator? About 45 to 50%. All of which disrupt your immune system, set you up for a certain, maybe a skin infection or something else, but then exposes you to antibiotics. And that generates the dysbiosis. That dysbiosis then generates a bizarre pro-inflammatory immune response that leads to other types of infections and maybe super infections, et cetera. And so if you look at trauma patients, this was 10,000 patients. Nosocomial infection rate was about 20%. And it was 4 times more in blunt than penetrating trauma for reasons I don't understand. But again, it's a big problem. It's a big problem not only in the surgical ICU, but I think hospitals itself. And this is an interesting study that was done, and they basically took what's called 16S RNA amplification. And basically they can take a swab, get the RNA out of it, and then run it through an amplification process and tell you what bugs are there. These are the bugs that are on the floor, on the workplace, and devices. So this is the defibrillator. That's the ultrasound machine. All of these, tremendous bacterial burden. And many of these are not meant to see human existence. Many of these are actually dirt related and are known to live in that kind of environment. Why is that important? Because when you live in that kind of environment, some of these bacteria have to be more virulent because of the hostile environment which they're in. And so many of these bugs that we're starting to see, these Acinetobacters and all of this, actually started as dirt pathogens that we've acquired over time, and now we brought them into a hospital. This was, again, 4% of patients get some type of healthcare related infection. That's a lot. In rapid rise, if you look at this, this was a study that they just went to the hallway of an ICU. They just randomly swabbed the nurse's tabletop, the chart, when they had charts, the computer top. They found almost 1,200 different species of bacteria just in the hallways. So we work in a very dirty place if you think of bacteria as really dirty. And that's got to be magnified in other places like the ICUs, like maybe the pediatric floor, but a huge bacterial burden. And the complexity of these interactions actually requires very concerted effort. And this was molecular medicine last year. And basically it said, we're trying to trick these bacteria, but we really need to try to understand them better. And I think what you're going to see at FCCM is really this push to try to understand these environmental and patient-related microbial mechanisms. And so I think it's just got to stop trying to enforce our will on these bugs. And that's what we're trying to do, I think, with repetitive antibiotic use. The other thing that we have to do is rethink SIRS and CARS. And for those that don't know SIRS and CARS, if you get an acute infection, you get a very profound systemic inflammatory response. How high that bump goes is genetic, as best we can tell. And through other stimulants like dendritic cells and IL-1RA, you actually then, to protect yourself, you get a counter-regulatory response. What we're finding is that somehow about here, we start getting this persistent inflammatory change. And this is where people just don't get better. They should be getting better. And you just see them, they're just not getting better. In fact, they're getting sicker. We just don't understand why they're sicker. And you see this all the time. And it probably has to do with this adaptive immune system, maybe much of it through the microbiota, but this starts becoming more and more separated. And this is what we're seeing is these patients that are in the ICU for 45 days and just can't get better. And much of it may be that we started with antibiotics and we didn't do anything to help with that microbiota. It's a big leap, but that's the way it's starting to look. So how do we try to manipulate this and make it better? Well, one is a nutritional paradigm. And we've looked at prebiotics and probiotics to try to restore this microbiome because really we're talking about the gut. Remember, 80% of your immune response comes from the gut itself, and probably 90-something% of your inflammatory response comes from the gut itself. And there's reasons for it. That's where the bacteria are for the most part. You also have skin, but you've got a better barrier. So the epithelium is not as good a barrier. The endothelium is not as good a barrier. And the reason is it wants to get some of this bacterial product down so that it can generate an immune response. So your adaptive immune also sets you up to be a little more susceptible to these bacteria in the gut itself. And just to show you how interesting these bugs are, and with quorum sensing, there was a study that was actually started here and finished in New Jersey, where they actually took animal lymph and they would starve these animals for about 3 days. And then they would cannulate the lymph and then take the lymph, culture it, would find no bacteria, then inject it in an animal, and almost all those animals died of septic shock. And what they found is actually E. coli can actually make spicules that can actually penetrate the submucosa and inject cytokines. And it does it to probably produce food, probably get some kind of a food advantage. But it does that particularly through, one, starvation, the second is through quorum sensing. So again, just these bacteria have a huge part of our life. Well, just to reintroduce you to prebiotics, prebiotics is kind of a food for the bacteria that are already there. And then probiotics is actually generating or giving bacteria itself. This is equivalent to the fecal transplants that we're starting to see in ICUs. And it's basically what you're doing is try to reintroduce good bacteria to try to stave off the bad and change you from an inflammatory to an anti-inflammatory state. In the effects of probiotics, there's been several trials. We know it improves your immune response, but it's not seemed to have been translates into improvement in outcome. So it doesn't mean I don't use them. It's just we can't really say that everyone in the ICU or everyone in the hospital that's getting antibiotics should receive them, but it is something to think about. And if you look at some of these probiotics, look at what they can do. They can change the luminal pH, the bactericidin production, the distribution of different bacterial communications, and then enhancement of the gut barrier, mainly by enhancing the submucosal lymph mass. And again, these things can do a lot. They're just not translating into improved outcome yet. This is sorry, very fuzzy bacteria, but part of the problem is we used to think these probiotics would just kind of shield the epithelium, and then the pathogen would come and they would block. That's really too simplistic. It's much more complex than that. And as we study this more, it's a very, very probably T-cell interactive process, but the probiotics, their effect is probably just to limit the number of pathogens that are out there. And so again, these studies are likely to reflect an oversimplistic view of the action of probiotics. We've not really tested it very well. All of the studies have been very heterogeneous. They haven't used the same probiotic. They use them in different patient populations and expect the same outcome. I think a surgical patient with a blunt abdomen is probably different than a Whipple, post-Whipple that's probably different than a MICU pneumonia. So, but when you try to throw them all into one pot, and that's what we do in critical care, to our disadvantage, and we shouldn't do it, is we try to one size fits all. And we try that, it never works, it never will work, but we keep doing it, which is the definition of sanity, right? So, is there anything that we can do now until some of these studies? Well, one is, can we reduce exposure to antibiotics specifically? And one of the ways that we're looking at doing is, can we particularly for pneumonias, and what we see most often in the ICU is tracheobronchitis or ventilator-associated pneumonias. Can we use aerosolized antibiotics so that they work topically, they're not being absorbed systemically to any degree, and not enough to at least disrupt the microbiota? And these are the ones that have actually been tested: vancomycin, the beta-lactase, or lactamase, it should be, tobramycin, monobactams with S-treonam, colistin, fluoroquinolones. All of these are in pipeline somewhere. Vancomycin, ceftazidime, tobramycin are all approved for inhaled use, and you can use them. The effects are variable. There was just this was a study that was done, but very, very low numbers. But it did show that if you look at patients that got randomized, these are growth factors without antibiotics, and these were with the aerosolized antibiotics, into treatment, you can really reduce the bacterial burden in the lung itself. And we're not seeing any resistant development, which is very unique, even from the lung pathogen, which is interesting, and no one can really explain to me why that happens. So again, aerosolized eradicated existing multi-resistant organisms and reduced the pressure on systemic agents. And this is what they're looking at. And there was just a recent review in actually middle of last year that showed that these look very, very promising, but no one's going to give a recommendation yet. But it is something that I think we can do and use, and they are approved to do that. This is a meta-analysis that was done on aerosolized, and it does show that we can use these aerosolized antibiotics, particularly for these respiratory infections, and there seemed to be some advantage, although quite small. So what about this? Well, the other place that we're looking at, these are antibiotics that are coming in the pipeline right now, and you'll probably see the first one out called immunosilin out in the next year or two, and it's a quorum quenching, they call it, quenching. And basically what it does is it's taking those quorum sensing molecules and blocking them. The advantage of that is you're not killing the bug, so that you're not threatening the bug. You're just telling it to turn off those pathogenic milieu and turn off that whatever signaling pathway that is making you sick from this bug. And these are quite interesting. We have several. This was a patent. I just went on Google patent, and they just found that I could actually take even smaller molecules of these, get high tissue penetration with these ligand and structure-based processes, and they don't kill the bacteria. They just turn it off and tell it doesn't need to be pathogenic anymore. And so this may help us quite a bit. So these are on the horizon. These are the ones that are in the pipeline. If you can see this, but this is basically the mechanism. It takes all of these pathogenic molecules and combine them. And so the cell then thinks it's alone. It doesn't have competition for food. Therefore, I can just sit here and be quiet and happy. The other thing that we can do is maybe improve our diagnostics. And antibiotic stewardship has been around forever. Blood culture has been around forever. But antibiotic stewardship has really been failed. And the reason it's been failed is because it's very hard to control the amount of antibiotics that are out there and the amount of antibiotics that need to be used. And more importantly, the collective increase acuity of our patients. They're sicker. They're going to get infected more just from their basic disease, but then if we throw antibiotics on them, they get worse, but we can't really stop doing it. And so antibiotic stewardship has not helped. But one thing that we can do is be better diagnosticians. Instead of saying, I'm not going to give you that antibiotic, maybe we could say, this is why I need that antibiotic. And if we can do it, blood cultures are not a very good test. If you look at it, they're too dependent on too many other things. You have to have a certain colony count per milliliter, which is why in most places it's 10 milliliters. You put 7 milliliters in the blood culture bottle, your actually chances of getting the pathogenic organism drops by 50%. So one, we don't put enough blood in the tube. Second, where does it sit? Sits in the nurse's station until someone runs it down, unless you got a tube system. They don't always tube it, but then what happens to it there? It sits in the lab for a little bit. And once it sits in the lab for a little bit, then they culture plate it or put it in the machine and see about its turbidity. We did a study. We looked at all the blood cultures for a month, in the month of December. We said, how many actually changed therapy? And it was 1%. So we get a lot of blood cultures, but when you get a lot of blood cultures, you get a lot of false negatives. Or false positive, I'm sorry, false positive, which exposes you to antibiotics. And then again, no one's around to stop them. And so qPCR is one way that we're looking. And the reason why we look at this is it's measuring the bacteria, and it looks at, this is one study, they looked at almost 16,000 species yielded by blood cultures. They were able to diagnose them 98.8% of the time, and they got the result in 6 hours. So as you draw blood culture 6 hours, they'll say, you get a panel back and said, not only will it tell you the bug, it'll tell you if it's MRSA. And there's one company that's in Alabama right now that actually we've tried to get here. It's approved, it's FDA approved already. It's just getting it in widespread use. And it's probably a little bit of technology limited. But it did it with very low colony counts, 3 colony counts, colony-forming units per milliliter, hit a rate of 50%, 100% in other types of bacteria. So it doesn't take a lot of bug. So this 7 milliliters versus 10 milliliters becomes less and less of an issue because it will do it so it have such sensitivity. This is another one that used a different type of PCR, but again, very high sensitivity, and it got a result to you 18 hours faster than a blood culture, even a positive blood culture. And this is it's called a film study. And this actually will get you very high clinical results. It has pretty high sensitivities. This is one study that you actually get the results in an hour. So that's an hour time it gets to the lab. So it's very, very high. So you could actually not even get them out of the ER and know what their blood cultures are. And again, if it's negative, you don't expose them to antibiotics. If it's positive, then you know probably what antibiotic, and then you don't do broad spectrum antibiotics, you do specific antibiotics because it has such a high specificity. And it's saved a cumulative of 14 bed days just by doing it in an hour. What about, this isn't how we round in the ICU anymore, but what about computational tools? Well, one thing that we're looking at, this was just put in JAMA Peds just a few months ago, and we're looking at adopting it here once we get it through everyone's agreement. And that is basically, you take the nurse and the resident, and so she calls you and says, I got patient X with a fever. Well, she gets out this check sheet and says, does he meet these criteria? And the resident does the same thing, because we do have different frames of reference. And if they don't meet that certain criteria, then they don't get blood cultures, and they don't get antibiotics. And the reason is we do it a lot of knee jerk, and that's what we're really trying to go. But they showed no change in mortality, no change in readmission rates, no change in readmission rates to an ICU, and they had no higher episodes of any other type of toward effect. So in concluding this, I think the microbiota gives us an understanding into why patients get very sick a lot of times. They understand, I think, better now nosocomial infections and innate immunity. Manipulating the microbiota may be a future. We've got to have better probiotics, I think, and more consistent. We can't really recommend probiotics right now except for, I think, C. diff, which clearly there's an advantage. And then in new paradigms in delivery. I think that's really important, and new types of antibiotics. And then faster diagnostics. And if you do start antibiotics, quicker de-escalation. If you get gram-positive cocci, and we see this all the time, they're on vancomycin, and their blood cultures come back gram-positive cocci, it's MRSA, and Zosyn never stops. And we've got to get out of that habit and de-escalate quickly and get more secure in doing that. And then maybe computational tools will help us be better decision makers to at least say, did you think about this? Did you think about that? Not to take over your care, but to just trigger you, say, did you think about this? Is this really meeting that criteria, so that we're actually giving antibiotics that meet standards of care? And that's it. You say great talks end on time, really, really good talks end early. So, any questions? Yes, ma'am.
I actually have a question about some of the source of this bacteria and the widespread use of antibiotics in our prey animals.
Yes.
In agriculture, they're everywhere.
Yeah, and it's when we say antibiotics with the microbiota, we're talking about diffuse use of antibiotics and antibiotic levels in foods that we don't know. And then the other thing that we have to do, and I think, we see is this pressure on practitioners to give antibiotics by patients, and that takes time. And, late Dr. Jackson used to say, RSV stood for Rocephin sensitive virus. And he was correct, because what happens, they go there, they get a Rocephin shot, because you ain't going to get rid of mom unless you do. And we have to get out of that mindset. Now that's going to take education, and it's going to take, being persistent, saying, sorry, I'm not going to give you antibiotics. You don't have a bacterial infection. In follow-up, because it's all about follow-up too. So,
that's great. Points out a lot of good points, but you also have to look at the macrobiotica. Somebody needs to work on the higher level, at the political level, that gets rid of the litigation environment which causes physicians to overuse antibiotics more and more and more and more, because they feel they are required to cover themselves. So it's multiple points and things there. And the other point is, you talked about aerosolized antibiotics. So that's been used with cystic fibrosis for decades. And I think the thoughts have been around for a while to try and do that, but it just hasn't caught on. And I think a resurgence of that is probably a good idea.
Yeah, and the reason it hasn't caught on is no one's been willing to do the study, because the money's in IV antibiotics, and because the doses are so much smaller in inhale, very, very small doses. And we use it all the time in cystic fibrosis. It works really well. We're just about to start a new trial with aztreonam in new onset Pseudomonas in infants and small children with cystic fibrosis. So it's catching on, but I think what we have to do is start just thinking about, like you said, more and more. But you're right, we've got to solve the macro-political process, because that drives a lot.
Liability atmosphere. The media tells all these families, you need a shot of antibiotics.
Yeah.
And we got to get rid of that pressure of people trying to run medicine, besides people who have practiced evidence-based medicine.
That actually read something other than Google. Yeah.
Speaking of enhancing or replacing biome, your numbers on C. diff are quite spectacular. Are you thinking that there might actually be more of a role for maybe fecal transplant, which we really...
Yeah, I think get a fecal transplant because it's really, you're doing the same as a probiotic. The beauty about the fecal transplant is you don't have to be smart about it. You're not trying to select it out which bacteria. Is it lactobacillus? Is it, Bacteroides? With fecal transplant, it's taking really huge biome. And you're talking about, at some of the studies, 3,000 species. So in that case, fecal transplant is something where I think in 5 years is going to be commonplace, particularly broad spectrum.
Is there any look into the antibody-impregnated central lines as to if that impacts greater or less on the biomes?
So the problem with the antibiotic is we've not really done a good job selecting, because we've done Rocephin and we've done silver impregnated. The silver impregnated seems to be the better way to go. And it does seem to reduce infections, but it's still the prep and the dress and the insertion of the central line. Now, if you look at ICP monitors and ICP drains, the antibiotic impregnated have absolutely changed the way that people do it. Now, here in the United States, we did this study, or did a survey a few years ago. 60% of all hospitals in the U.S. keep people on antibiotics for the entire duration of their ICP monitor. If you go to Europe, almost no one does it. You go to Australia, and they won't let you do it. And they have no higher infection rates, but they use antibiotic impregnated. But it's local and focal, and it's not affecting that the biome. So we've got to, again, get smarter on a lot of different levels. And main thing is, and what you see a lot of these is we're drawing way too many blood cultures, way too many from central lines. A lot of central lines get colonized, but that doesn't mean you're infected. But they're getting antibiotics. And so, again, I think we just got to get smarter about, and that's why I think one of those tools that trigger you to say, really, is this really necessary? Why don't you recheck them in 6 hours and see what they look like?
Regarding the antibiotic impregnated central lines nationwide, I think they're using in the ICUs where their infection rate of CLABSI is higher than a certain.
Right. In burn units and other things. I guess I didn't clarify that. There's no data in central lines that show silver better than Rocephin, but no central line has shown anything better other than good insertion technique.
And I had a question about talking about silver-coated ET tubes for the VAP, and the data is they delay in the occurrence of VAP, but there's no decrease in the incidence of VAP.
Right.
Is that the correct thought process?
Yeah. And the posterior suction tubes, the non-cuff disc tubes may have an advantage, but they don't stop the incidence. They just delay it a day, day and a half. And this is where I think, maybe making our immune system better early in the ICU course, because really, nosocomial infection starts at what? Really, day 7, when they start counting it, particularly as a CLABSI or a VAP. So, we can stop giving antibiotics in day 1 and 2, or if we give them, de-escalate them quickly, then maybe we prevent that by just bolstering their immune system.
So it's very interesting and exciting that we have a blood PCR that will isolate bacteria. I'm wondering would that give susceptibility pattern in the future, or do we have any such kind of test on urine so we can diagnose UTI on urine?
It doesn't give you sensitivities, but it does give you resistance. So, for example, in staph, it will tell you if it has the gene for MRSA, as an MRSA bug. Also, I guess the Klebsiella has a resistance for imipenem resistant. I know that it has that one, and I think those are it. So it'll tell you the bug, and it'll tell you the likely, but then that's when you go to your antibiogram, which is why cultures aren't going to really stop. They're just going to be, I think, we can diagnose faster, then we get susceptibility, and that's when you can really tweak your antibiotics, unless you know it's MRSA from the start, and you're not going to give them Afcel, and you'll give them the vancomycin.
What type of criteria are on that checklist that will help guide if cultures are indicated?
It's a lot of that. Their hemodynamic status, is this their first fever? How long has your central line been in? Do they still need a Foley? It's a lot of just mental check marks. And it's just, I can send it to you in PDF, but it's mainly just those triggers to say, I'm just not going to start antibiotics because they have a fever. I want to make sure that because if you look at how many patients, in the ICU, like I said, 38% get antibiotics, but if you look at the infection rates, actually not that terribly high when you look at atelectasis, DVT, drug reaction, those issues.
Is there going to be any policies put out on this? Because I know that ICU and the floor, especially on peds, have very different approaches to when they start antibiotics and when they don't. And so, it's just, is there going to be like a lean towards making a policy for when we should do this, or is it just going to be more guidelines we should follow?
Well, what we're hoping to do is if this checklist, because it just got validated, we've had checklist out for a while on this. This is the first one that's been validated in peds in the ICU, so that's where we're going to start it. And then if it looks, and we'll have to monitor it for 3-4 months and see how our results are, and if that looks good, then I think it would be a natural thing to progress it to the floor. But we're going to start in the ICU. Hopefully, we just got Dr. Bikini's blessing on it, so hopefully it won't be long, and we'll get some policies out there.
The problem with some of those checklists is just like the small baby with a fever from 3 to 12 months. There have been multiple checklists out there that associate with occult septicemia, and they've been printed, but how many people actually really stop, look at that checklist, and say, they probably don't have occult septicemia. They still do a blood culture, give them a shot of Rosefin, send them out the door with an antibiotic prescription. And so it will probably happen in academic centers like this, but out in the real world, they're still going to promote all those bad habits.
Yeah. Well, this will be
Hopefully with time.
train a generation. And I thank y'all very much.